Okay, so my agenda today is to entertain any questions over what we've talked about so far on the endocrine system. You know that on Thursday we have an exam. That exam covers skeletal, physiology. Most of that, I've said this over and over, and I hope you agree, most of that was review. It wasn't a lot of new material. What was sort of new in that presentation was the parathyroid hormone and the calcitonin. That physiology was new, but most of it was rather straightforward, a couple different fracture types than what I think you've seen before. Then in the autonomic nervous system, again, that was largely review. I hope you agree. Sympathetic versus parasympathetic. And then the big emphasis on this exam is going to be on the endocrine system. Last time we went through, we talked about different types of hormones, right? There's amino acid derived, there are peptide derived, and there are lipid derived or cholesterol derived hormones. And we discussed how they travel differently through the blood and the receptor types that they must have. Obviously, if something is a lipid, it doesn't blend well in the plasma, right? It has to be carried, but then it can travel right through the nuclear membrane and the cell membrane and have receptors inside the cell. If it's a protein, it is likely going to be carrying through the blood on its own, but it's going to require a receptor at the cell surface in order to interact and cause changes on the inside. And we also mentioned two different types of second messengers, because those hormones don't enter the cell, do they? Lipid hormones enter the cell, don't they? The whole molecule enters the cell and does something. But the protein hormones bind a receptor, and then something magical has to happen on the inside, and that was that cascading or the second messenger system that oftentimes works through cyclic AMP or through calcium and calmodulin. Briefly mentioned it, just kind of look at those different systems and how they work. Your job as you're going through this is to know what are the hormones, where are they released from, and where are they targeting, and what's the physiology behind it, just in a general way. We'll be talking a lot more about these hormones later on. When we get to the reproductive system, we'll talk a lot about estrogen, progesterone, and testosterone, more specifically. When we get to the digestive system, we'll talk more about some of these. When we get to the cardiovascular system, we'll revisit ANP. When we get to the kidneys, we'll revisit renin and angiotensin. So no, you're going to be hearing about these again. Now it's sort of a big global idea of this. On Thursday of last week, we were able to get through the different types of hormones. We know the basic placement of these hormones in the body and the glands that make them. We got through the hypothalamus, and we got through the pituitary gland, both the anterior and posterior pituitary. And we talked a little bit about negative feedback. And we got to the thyroid gland. And I said at the very end I would pick up here, didn't I? So at the very, very end of the thyroid gland, and I'm not going to belabor this, thyroid hormone, okay, comes in two flavors. Okay, we're picking up, what page is this? Picking up on or around page, no pages, 15, 16.7, thank you. So thyroid hormone, when you hear that, it actually comes in two flavors, T3 and T4. T3 has 3 iodide molecules attached to it, T4 has 4. That's the only real difference that I want you to appreciate. And that iodine, therefore, is necessary for thyroid function. So if you have an iodine deficiency, you would have thyroid hormone deficiencies as well. And I mentioned last time that that's when Mr. Morton and the U.S. government got together and decided to iodinate salt. And so we no longer see iodine deficiencies in this country because of the iodination of salt. 75% of T4 and 70% of T3 travel in the blood attached to transport proteins. As long as they're attached to a transport protein, they're not biologically active, right? They're locked up, they're carried, they're like in the back of a semi. They can't get out, they can't do anything. So we talk about bound versus free. Now the molecule holding onto these is thyroid binding globulins. And the fact that T3 and T4 are being carried suggests to you what about their nature? They are hydrophobic, right? They are fat-like, they're steroid-like, even though They are what sort of molecule? Are they amino acid or peptide derived? They're amino acid. So they're very, very small, but they don't mix well with water, right? So they are hydrophobic. They need to be carried through the body. So that's kind of different because up until now, when you thought about hydrophobic or steroid hormones, you were thinking about the ONs, right? Aldosterone and progesterone and all of those. And those are all cholesterol-based hormones. But this is an exception to that general rule, right? These very small molecules are hydrophobic. So again, if you understand or appreciate this idea that these molecules must be transported, then you're really doing okay. You'll also see that T4, 90% of the thyroid secretions are T4. So this is the major one, and less than 10%, and they are going to enter into the bloodstream. So they're going to be made and enter into the bloodstream just like any other hormone, and then they're going to be carried, like this says. They're going to be carried through the body with this thyroid binding globulin. What are they going to do? Look at the surface, just the big idea here. What do we see in this picture? Here's a capillary, and this little oval is the thyroid binding globulin, or TBG in the picture. And that's the carrier, right? So this molecule is not able to travel through the blood without being carried. If it's free, a very small percentage of it will be free, but if it's free, it's able to hop out, right, and bind to or enter into a cell. How does this stuff enter? Do you see a receptor on the surface? Do you ever see a receptor? No. So the receptor here, because this is hydrophobic, is able to go in and out of the cell. That's really where I want you to go with this. I don't want you to get too crazy about this. We don't have time for that, and it won't be focused on it all on the exam. What I do want you to appreciate, though, is what do thyroid hormones do? Thyroid hormones increase your rate of oxygen consumption. They may raise your body temperature. They're going to increase your heart rate. They're going to increase your sensitivity to sympathetic stimulation. Okay. They are going to help maintain your respiratory centers. They're going to be a big part of your red blood cell production. So if you're thyroid deficient, you're going to be kind of anemic, right? You're not going to be having enough red blood cells.
So for the diffusion across the plasma membrane,
yep.
Back towards the beginning of the lecture, when
yes.
we talked about thyroid hormones, it says they were transported across the plasma membrane.
Yes.
And one of the mastering questions is about that. It says that it's transported.
It is transported. It is transported.
Diffusion.
It is sort of a combination. Can I just agree to go on with that right now?
Yes.
Okay. I assure you I'm not going to pull that apart for you. Look what else it does. It stimulates other endocrine tissues and it accelerates turnover of minerals. So if you are thyroid deficient, long-term, right, anemic, not enough red blood cells, overall functioning not very well, sympathetic, kind of sluggish, right? Not a lot of metabolism, slow metabolism, and usually some weight gain that goes with that if someone is hypothyroid. If you're hyperthyroid, then what? You might have a, quote, faster metabolism, and your heart rate might be a little bit higher, right? Faster heart rate, more red blood cell production, and with that comes more metabolism overall. So just think about overall, when I think about, look at this, what thyroid hormone does to aid in calcium. I just mentioned that it has something to do with blood cells and with mineral turnover. Let's keep going. Let's get through our what I'm going to call the parade of hormones. Parathyroid, this is a revisit back to bone chapter. Parathyroid, remember this gland is on the posterior side of the thyroid gland itself. Very small, usually 4 little glands, sometimes only 2, sometimes as many as 6, but usually 4 in the average person. This picture shows 4. You're looking definitely at the posterior side of the thyroid gland. So the rest of that thing you're seeing is thyroid, right? The orangey stuff is thyroid. Just a little purple are the parathyroid glands. Now there's 2 different kinds of cells in the parathyroid. And the one that makes the parathyroid hormone are the parathyroid cells. Isn't that easy? They're also called the chief cells, right? Sort of the most important cells. The other cells, we really don't even know what they do yet. Isn't this amazing? We don't really know the function of the other cells. But the parathyroid or the chief cells are the ones making the parathyroid, and we know that they're released when? Parathyroid is released when calcium levels are too low. So what will parathyroid hormone do? Cause an increase in calcium, right? So that's what it's going to do. It's going to cause an increase in calcium. So it's going to be monitoring. Now, not only are the parathyroid cells monitoring your calcium levels, but so are the thyroid C cells. Remember, the C cells were the ones that made what? Calcitonin. And these two are working with each other. They're antagonistic hormones. I'll use that word again later. But they're hormones that work, and they're kind of yin-yang, working off each other. Remember that calcitonin is going to be what? Released when calcium is too high, and result of that hormone would be to drop blood calcium levels. I'm not going to ask you to look at histology, so we'll skip right over that. And again, this is these hormones have opposing or antagonistic effects, and typically in a healthy adult, parathyroid hormone is the primary regulator. Okay, it's the primary regulator. Removal of the thyroid gland has no effect on calcium. Okay. We can then give, because you can give someone calcitonin clinically and help them out with that. If someone has their thyroid gland taken out, they usually will also lose the parathyroid, but not always. Okay, it just depends on the surgical procedure. So taking a look at the little picture here, kind of the little diagram. So here, increased calcium levels, we already know this story. Increased calcium levels, the thyroid gland is going to produce calcitonin that comes from those C cells. That's going to increase the excretion of calcium and increase the calcium deposition. You have a lot of calcium, right? Let's have a party, let's build up bone, and that's going to help restore your levels. If instead your calcium levels are low, parathyroid is going to release PTH. That's going to increase the reabsorption by the kidneys, increase release from the bone, and also increase absorption into the GI tract. And I think that figure is something very, I hope you feel comfortable with that, right? Calcitonin and parathyroid. Yes?
Calcium release from bone is it saying PTH excites osteoclast?
So what would calcitonin do? Calcitonin is going to be released when calcium's too high, right? So what do you want to do? Use that calcium and get rid of it out of the blood. One way would be to increase bone production. So that's going to increase your osteoblasts. Versus parathyroid hormone, your calcium's too low. And so what do you want to activate? You want to release calcium, so you're going to increase the chewing up of bone by the osteoclasts. Good connections. Okay, so you can read about that here. Again, it just talks about the osteoclasts and the osteoblasts I just talked about. Just know the basic story here. Don't worry about the rank L. If you read about rank L, I won't deal with that on the test, so don't worry about rank L. So that's a quick little thing about parathyroid. Let's go to the adrenal glands. Now, the adrenal glands, or the suprarenal glands, are sitting on top of the kidneys. Just like the kidneys, they are retroperitoneal. Just like any other endocrine organ, they're rich in blood, so they're going to be rather red in color, rich supply. But because they are sort of embedded in fat, the general appearance of the adrenals will be yellow. But if you took that fat layer away, then you would notice that they have a high vascular supply and are quite red. Now, the adrenal gland is a lot like the pituitary gland. It's really two glands smushed together. The anterior and posterior pituitary we've talked about, but the adrenal gland has a cortex and a medullary region. It also has a capsule on the outside. So it's sort of like the kidney. It has a connective tissue capsule on the outside. But then just inside of that, you've got the cortex. And the cortex is where you make many of your steroid hormones. Not all of them, right? Estrogen, progesterone, testosterone are made by the gonads, but most of your steroid hormones are made here, and they are the ones that are made here are called the corticosteroids. It makes sense. They're steroids from the cortex. So the corticosteroids. Now, there are 3 different layers that we'll talk about here of the cortex, and I'll give you a way of remembering this in a moment. These are really, really important. People with adrenal issues, they are in a lot of hormone replacement. The inside of the adrenal gland is the medulla, and this is basically where epinephrine and norepinephrine are made. So this is your sympathetic nervous system. The other name for epinephrine is adrenaline, right? Because it's coming from the adrenal glands. So adrenal, adrenaline, epinephrine, same thing, just a different name for the same thing. So again, we're looking, we know where these things are. They're sitting on top of the kidneys, the superior border. And if you were to slice into an adrenal gland, you would see what's shown here. Again, the outer layer is just a capsule on the outside. That's just connective tissue. The vast majority of it would be a rather thick cortex. And that's where the corticosteroids are coming from. And then the center would be the medulla. So let's talk about the cortex. There are 3 zones. 3 zones. The zona glomerulosa. Okay. This outer layer of the cortex is releasing mineralocorticoids. These hormones are especially related to mineral regulation, and the one you know and love is aldosterone. So that's what I want you to focus on. You know about aldosterone. You know that aldosterone is involved with sodium retention and sodium levels. You've learned about that one already. So when you think about the outer layer, the zona glomerulosa, think of aldosterone there. Okay. The middle layer is the zona fasciculata. This is where the glucocorticoids are made. The one I want you to know specifically, cortisol. Okay, cortisol is a hormone that we'll see toward the end that deals with sugar use, and I'll tell you right now, secretion of these hormones is stimulated by ACTH. What is ACTH? Adrenocorticotropic hormone, right? So what are we talking about? A hormone that influences the adrenal cortex. So that makes sense, right? So ACTH is going to help increase these adrenal cortical hormones. What gland makes ACTH? It was one of the hormones released by the anterior pituitary. And then the inner layer is continuing, zona fasciculata. This whole region, the hormones made here, like I said, are cortisol and other glucose or sugar-related hormones. These hormones all affect glucose metabolism. They're going to increase rates of glucose and glycogen formation, and they're going to stimulate the release of muscle amino acids and stimulate the release of lipids from adipose. What does that sound like to you? If I'm going to increase glycogen, what is glycogen? It's a long polymer of glucose that is stored in our liver for a rainy day, right? It's stored there. So these hormones are involved with sugar metabolism. If you just think about that, a lot of energy and sugar metabolism. There's also a lot of evidence that cortisol has an anti-inflammatory effect. And we'll talk about that when we get to stress at the end. The third layer, the inner layer, is the zona reticulata, or reticularis. And this is just a very thin layer down by the medulla. And here you've got androgens. Now, when you hear the word androgen, you normally think of testosterone and male hormones. But women do also make androgens, and they're made here in the adrenal gland, specifically in the zona reticularis. The androgen here has very little effect in adults, but if there's an overproduction, if a woman or even a guy has a tumor of the adrenal glands, and that gland that tumor is over-secreting some of these androgens, then it can have, in women, basically effects of secondary sex characteristics in a man. You can have deepening of the voice, you can have facial hair, things like that developing. Again, stimulated by ACTH, it makes sense, right? All of these hormones are going to be upregulated by ACTH. So that's the cortex. Now, another way of thinking about that, let me back up. What were the three layers? We had the G. Oh, here we go. G, F, R. Now, you may know GFR is glomerular filtration rate. Maybe that makes sense to you back in the kidney. But we'll talk about that later in the course. But GFR, glomerulosa, reticularis, fasciculata, and reticularis. Now, what was made in these? In the outer layer, I told you, aldosterone and minerals, or salt, right? Salt-related enzymes, or hormones. In the fasciculata, what do we have? Sugar. And in the reticularis, androgens, think sex. So salt, sugar, sex, okay? The three layers. Salt-related hormones on the outside, sugar-related hormones in the middle, and sex-related hormones on the inside. Salt, sugar, sex. Now moving into, I should say, the medulla, and this is where epinephrine and norepinephrine are being released in large amounts. And you know that if the bear is chasing you and you're in a sympathetic overdrive, that these hormones are going to increase your cardiac activity, increase your blood pressure, increase your respiration rate, increase glycogen breakdown, right? So glycogen breakdown, why are you breaking down glycogen? Because you need the energy, right? Your fight or flight, you need that energy. What hormone worked against that? What hormone was about glycogen production? Just a moment ago. The cortisol, right? Okay. And so this is going to increase blood glucose. And we know a little bit about this. As you think about the autonomic nervous system, you know a little bit more about epinephrine from that conversation. Here are those layers. I'm not going to ask you to know these from a histological standpoint. But again, the down here in the very bottom is the medulla, and then here's the R, fascicularis, and the glomerulus. So GFR going down, and they're pretty distinct bands. I mean, you can actually, on histology, see distinction in the tissues. I'm not going to ask you to differentiate those, but now you have a visual idea of what we're talking about here in these layers. And then this is nice. And then it's a nice little table. This is coming from your textbook. This is figure 16.9. And again, talks to you about the major hormones here. If we take a look in the glomerulosa, that's the outer one, right? And what was made there? Mineral-related hormones or salt-related hormones, aldosterone. And what's the primary target of aldosterone? Kidneys, right? We know that. And on the fasciculata, the glucocorticoids, they're kind of affecting all cells because they're kind of looking at overall sugar and metabolism and energy. And the androgens, what do we know? What does testosterone do for guys? It maintains their muscle mass, maintains their blood cell count. And so what you see is that the androgens go to skin, they go to bones, and again, they don't have much of an effect in you and me, but if there is a tumor or some abnormal situation, then you can really see the effects of these androgen hormones. Also notice that the fasciculata and the reticularis are stimulated by ACTH. That makes sense. Adrenal cortical hormones. And you already know that renin, right, stimulates aldosterone. ACTH, adrenocorticotropic hormone. Adrenocorticotropic hormone. It's one of the seven hormones produced from the anterior pituitary. Okay? And it makes sense, right? The name tells you that it's tropic, it's influencing the adrenal cortex. Okay, so again, we're just doing I'm calling it a hormone parade, right? Kind of moving through. Now we're to the pancreas. Now, if you were to ask the average person about the pancreas, they would probably say insulin, and they're right, right? But the production of insulin by the pancreas is really only a very small part of the insulin's function. The majority of the insulin is really involved with digestion, right? It's really involved with making digestive enzymes and helping you break down food products through your digestive system. But a small portion of the pancreas makes hormones. That makes the pancreas both exocrine and endocrine, doesn't it? Because it's involved with exocrine functions in the digestive process, and it's making a number of hormones. That makes it part of the endocrine system. You know where the pancreas is. It is mostly retroperitoneal, along with the kidneys. And here's what I was describing. About 99% of the volume of the kidney is actually exocrine, dealing with the release of pancreatic enzymes. The pancreas is also releasing a very alkaline fluid. Why would that be? Why is it important that the pancreas release alkaline fluid? Yeah, can you picture where the pancreas dumps its products into the intestines? Right after the pyloric sphincter. Right after the digestive products leave the stomach in that very acidic environment, it then enters into the small intestine. And it's right there at the very beginning of the small intestine where the pancreas and the gallbladder dump bile and pancreatic juices. So it's important that the pancreas provide an alkaline environment because the intestines are not designed to withstand that low acid, or the high acid, that low pH. A very small percentage of the pancreas is involved with endocrine function, and these little 1% of cells are kind of clustered throughout the pancreas in little island-like structures, but they're referred to as islets, okay, islets. And they were described by a name called Langerhans, so guess what? His name is still stuck on them. The islets of Langerhans. This guy also is the guy who described the macrophages in skin, right? They were the Langerhans cells. So this guy has his name on a few places in a physiology textbook. About 2 million of these little islets, when you see the word islets, you can think island. It really is kind of a little cluster of cells, kind of isolated from everything else. So here's the pancreas, right, just in general. And it's sitting right there like I just described to you, and it's emptying its products at that duodenal papilla, remember that? And it's that little spigot where the bile and the digestive juices are dumping right into the intestine. The stomach would have been dumping in right here, okay? Right at the very beginning right there. So these islets have a few different types of cells. The alpha cells are these cells that specifically release glucagon. Glucagon, not to be confused with glycogen. Glucagon is a hormone. It is the antagonistic hormone to insulin, and its job is to raise your blood glucose. So maybe you haven't eaten since lunch, and as a result, your blood glucose is a little bit low. And the reason glucose is so critically important in your blood is that your brain only runs on glucose. And so if your blood glucose levels are getting low, the body is going to do some things to assure that the brain has enough energy. And so glucagon will be released, and that is going to increase or raise your blood glucose. Well, how do you think it's going to do that? Glucagon, as a hormone, is going to tell the liver to do what? Break down and release sugar from the glycogen stores, right? So the glycogen is the storage of glucose, and it will tell the liver to release some of that. The other cell, well, one of the other cells in these islands, in these islets, are the beta cells. Beta cells specifically produce insulin. This is the hormone you probably know the most about, just because diabetes is such a prevalent condition in our country. So what does insulin do? Insulin causes your blood sugar to go down. So after a meal, and you've had some carbs or some starches or whatever, your blood glucose levels go up. The insulin then triggers to all of your cells, hey, let's have a party, let's eat. And it tells your cells to go ahead and take that glucose into the cells, thereby reducing the sugar levels in your blood. So this is going to increase your glucose uptake into cells and increases glycogen production by liver and muscles. So again, glycogen production is doing what? Building, right? Taking glucose and knitting it together into a long polymer called glycogen. So we've got insulin and glucagon, opposite effects. Glucagon made by the alpha cells, insulin made by the beta cells. There are also in these little islets some delta cells. Delta cells produce a hormone that's identical to growth hormone inhibiting hormone. Now normally, if you heard about growth hormone inhibiting hormone, you're thinking what? All the inhibiting and releasing hormones are made in the hypothalamus. But this is identical to, it's not the same, but it's identical to GHIH. And what would this do? Growth hormone inhibiting hormone would basically say what? It suppresses both the release of glucagon and insulin and basically slows down the whole digestive system. What you're going to see is that the pancreas, from a digestive standpoint, makes important enzymes, makes the alkaline solution, but the hormones made by the pancreas are also very much involved with the digestive system, but here now more controlling it. So the glucagon and the insulin are involved with sugar breakdown and utilization of sugar, and the delta cells basically says, you know what, let's kind of slow this whole thing down. We want the food to stay in our gut long enough so that things can be absorbed. And then the F cells produce pancreatic polypeptide, PP. Okay, and this is going to inhibit gallbladder contractions and may also help regulate the rate of nutrient absorption. So alpha and beta are the big ones here, to be honest, insulin and glucagon, but I do want you to know about delta and F cells also. If you were to take a cartoon representation of this, everything here on the outside would be the pancreas, right? So huge, huge, huge. And there'd be this little island of cells called an islet. And within that little islet, there'd be some alpha cells, some beta cells, some D cells, and some F cells. And each of those cells makes something specific. Now, a type 1 diabetic, one who no longer makes insulin, his or her beta cells are gone, right? They don't make, they have lost their beta cell production, and the beta cells no longer make insulin, and so that patient is insulin dependent. That's a type 1 diabetes. We'll talk about diabetes in a few minutes. So everything you're seeing here related to the pancreas and these islets is dealing with glucose homeostasis. You've got the increase and decrease of glucose levels by insulin and glucagon. You've got, and then you have, as you see, as blood glucose rises, this is important to know. As blood glucose rises, beta cells release insulin. That increases transport of glucose into all the cells of the body. And as blood glucose declines, instead glucagon will be released by alpha cells, and this is going to stimulate glucose release. Opposing effects. And this little yin-yang slide or diagram is probably useful for you to look at if you're having struggle with this. This is 1610. Nice little diagram. Goes through what's going on with glucagon and insulin. Those are the two big ones. Oops. We'll watch this just for a variation here.
The sugary snack you devour enters your digestive system and is broken down to simple sugars like glucose. Glucose enters the bloodstream, causing an increase in blood glucose levels. But various mechanisms bring blood glucose back down to its normal level, the set point. This is an example of homeostasis, body's tendency to maintain relatively constant internal conditions. Hormones produced by the pancreas regulate blood glucose levels. Let's zoom in. When blood glucose levels are high, glucose molecules leave the blood and enter beta cells in the pancreas. The beta cells respond by releasing the hormone insulin. Insulin enters the bloodstream and is transported to cells all over the body. Let's see what happens in the liver. insulin binds to receptors on liver cells. This causes the cells to take in more glucose. Inside the liver cells, glucose is converted to glycogen, a storage molecule. Blood glucose levels decrease as glucose is taken up by liver cells and other body cells. As a result, less and less insulin is released by the pancreas, and blood glucose levels stabilize at their set point. This is an example of how negative feedback maintains homeostasis. What happens if you've skipped lunch and your blood glucose levels are low? Let's zoom into the pancreas again. When blood glucose levels are low, alpha cells in the pancreas release the hormone glucagon. Glucagon enters the bloodstream and acts on target cells in the liver. Glucagon binds to receptors on the liver cells, signaling the liver cells to break glycogen down to glucose. Glucose is released. And blood glucose levels increase. As a result, less glucagon is released by the pancreas, and blood glucose levels stabilize at their set point. In this way, two hormones with opposing effects allow the body to maintain homeostasis of blood glucose levels. In diabetes, the body is unable to maintain homeostasis of blood glucose levels. In type 1 diabetes, the beta cells of the pancreas are destroyed by the immune system, and so no insulin is produced. In type 2 diabetes, the pancreas produces insulin, but target cells do not take up glucose. In both types of diabetes, when blood glucose levels rise, cells do not take up the additional glucose, and so blood glucose remains high. This example shows the importance of homeostasis in everyone's life.
Now, what's the problem with high blood glucose? What's the long-term effect? What happens to diabetics long-term? If they don't maintain their blood glucose levels and they maintain high levels, what are the problems? Well, over time, that high blood glucose, we know, damages nerves. So it causes microvascular problems with capillaries, and people with diabetes are at higher risk of stroke and heart attack as a result of it. It also affects nerve endings. So people with diabetes oftentimes, especially type 2, complain about tingling and pain in the feet or even complete numbness, nerve damage in the feet. And another complication of diabetes is blindness. Again, because blood vessels, small capillaries, are damaged by high glucose over time, diabetics are higher risk for eye damage. Again, high blood sugar damages blood vessels and nerve endings, nerves. So that's really the problem. That's the issue, and why it's important that diabetics maintain their blood glucose levels well to minimize those long-term effects. Okay, that's it for the pancreas. Not a lot, right? Alpha and beta are the big ones, glucagon and delta, or glucagon and insulin. The pineal gland, where is it? It's up in the brain. It's in the diencephalon region, the pit, the core, the center of the brain, in a layer specifically called the epithalamus. So it is a little tiny section. The cells here are called pinealocytes, right? Pinealocytes. These are just little cells of the pineal gland. And these cells are producing melatonin. Melatonin is related to serotonin, right? Serotonin, one of the neurotransmitters, and definitely has a lot to do with 24-hour cycles and circadian rhythms. And it makes sense. Some of this information from the pineal gland, some visual pathway, some information from your optic nerve travels and goes to the pineal gland and has an effect on the release of melatonin. So melatonin definitely has to do with setting our night and day rates. The rate is lowest during daylight, it's highest at night. People who are traveling, they know they're going to be crossing time zones. Sometimes we'll take melatonin to help adjust to the time zone differences. So again, don't worry about the histology, but we're talking about this little tiny section right back here. That is the epithalamus. So hypothalamus, right above the pituitary, epithalamus. If I were to, or anyone ever points to a small little area toward the back of the brain, and we're talking about the endocrine system, you know that has to be the pineal gland. It's certainly not the pituitary or the hypothalamus. Okay, again, it's going to, melatonin also has, it inhibits reproductive functions. It may play a role in the timing of sexual maturation. You know, when does puberty start? Melatonin levels decline at puberty, so that may be part of it. And pineal tumors that stop melatonin production may cause premature puberty in children. So, you know, when you read about in the Guinness Book of World Records about, you know, 3-year-old girls who are menstruating, clearly something else is going on and has something to do with probably the pineal gland. The pineal gland also has an effect in protecting us against free radicals, so it may also be important in protecting nerve tissue from those free radicals. Again, something to do with the circadian rhythm and the cyclic nature of our day and night patterns, and melatonin secretion is increased during darkness. This has an effect on us in Michigan during the winter months, because melatonin levels go up during darkness, during the winter months when we have fewer daylight hours, and that may have an effect, that increase may have an effect on seasonal affective disorder, right, SAD. And so that's why, you know, some people are a little more gloomy in the wintertime. They have SAD, seasonal affective disorder. How do you fix it? Sit under a light, right? Get one of those lights and sit under it. Don't let too many hours of darkness go by without sitting under some light. And that will actually affect people's mood and their eating habits and their sleeping patterns quite positively. So that is the pineal gland. Again, our march through this. Okay. Next, a few clinical disorders, specifically diabetes. It's the big one. So let's talk about diabetes. But before that, is there anything I've said so far, any of the hormones so far, melatonin, anything in the adrenal glands? Let me quiz you on that really quick. What were the 3 layers of the adrenal cortex? Outer layer? G, right? Right, you don't have to write this out. So G, middle layer, F, and inner layer, R. G, glomerulosa, responsible for hormones related to salt and minerals and therefore aldosterone, and turned on by renin. And then in the F, fasciculata, hormones related to sugar. The hormone I told you no was cortisol, and turned on by ACTH. And R, reticulata, sex, the androgens, also turned on by ACTH. Okay, good. And then in the medulla, epinephrine and norepinephrine. Good, sympathetic. Good. So let's talk about the 2 different types of diabetes. Now, there's still a lot of research going on. The term is derived from the word for honey. And diagnostically, during Greek times, there's mentions of diagnosis of diabetes if someone's urine drew ants to it because it was sweet, had more glucose in it, then the person was diagnosed with diabetes. Now, in those days, there wasn't a whole lot you could do about it, and diabetes was definitely a death sentence, an early death sentence, especially type 1. There was really nothing that we could do really until about 60, 70 years ago when they started grinding up pig pancreases, right? And they would grind up pig pancreases and collect from it insulin, and people were living on pig insulin for years. Now, with recombinant technology, we now are having bacteria make human insulin and are making it in buckets full, and companies are making a lot of money off buying or making these different forms of insulin. So the big thing about diabetes in general are these characteristics. A person who has hyperglycemia, emia, abnormal condition of the blood, hyperglycemia, glucose, right? High sugar levels of the blood. They could have glucosuria, would be sugar in their urine, and polyuria, excessive urination. Why would a diabetic have polyuria? Solutes suck, right? So if you're releasing more sugar, with it will go water. So these individuals are always very thirsty as well. Lots of, they're drinking a lot because they're losing a lot of fluid in their urine, more than the average person. So some of the signs of a person who might be dealing with diabetic changes: high glucose, you're not going to notice, but thirst and increased urination certainly can be noticed by the average person. A couple different types that I'll describe. Type 1, this one, we really don't completely understand why. Some people suggest a viral infection, something that destroys, some sort of autoimmune situation in which the beta cells are destroyed. As a result, these individuals no longer make insulin, and they must have daily injections. Typically, now people get pumps, so these pumps are constantly sending in some insulin into the body, and they crank it up a little bit right before a meal. Type 1 diabetics are trained to look at their plate of food, figure out how many carb grams they're eating, and dial up appropriately as if their pancreas was about to spit out some insulin following a meal. If you overdo it, though, what happens? If they overshoot the insulin, then their blood sugars will drop way too low, and they could go into a coma or some sort of diabetic coma, or into a fainting situation, very, very weak. And so they always carry around some lozenges, some sort of, something sweet, in case they overshoot their insulin. This is more often in young children and young adults. It was oftentimes called pediatric or juvenile diabetes for historically. We've gotten rid of that word because it's not true for all cases, but historically, if you hear about juvenile diabetes, this was type 1. Okay, but it's now just called type 1 most often. 5 to 10% of all diabetics are type 1. Type 2 diabetes, again, for reasons that are completely understood, the pancreas is typically still making normal amounts of insulin. The problem is the receptor. So the insulin receptor in the liver, primarily, and other cells, is no longer responding to that insulin, and we will refer to this as insulin resistance. So even though the pancreas is cranking out insulin, the body is not responding to it. The body is resistant to that insulin. In fact, the body may overproduce insulin, right? Because it's trying to make an effect, it's not happening, and so the body will crank out more insulin. And there is a definite connection with obesity here. It's not completely understood if the obesity is causing the diabetes or if the diabetes is helping to contribute to the obesity. It seems to be a big, giant circle of, difficult management. Clearly, though, people with more exercise and diet and weight loss can reduce the effects of the type 2 diabetes. You'll hear people say it's been cured. No. Endocrinologists will say type 2 diabetes is never cured, but it can be brought under control quite well with diet and exercise. Now, what would exercise be doing? How would exercise help a type 2 diabetic? What does exercise do? It's using up energy, right? And so you're clearly going to be helping your own body get rid of some sugar levels that are high by simply exercising and losing weight also. That connection between adipose and diabetes is still a huge hot spot of research, trying to understand how fat cells may be communicating with the pancreas and somehow regulating or working together in this type 2 diabetes. Now, this is the silent diabetes, right? Because people with type 2 diabetes can live their life quite normally. They don't necessarily know they have this condition. The diagnosis for this has increased in part because the threshold of sugar has decreased. It used to be your blood glucose had to be about 140. And then a few years ago, they reduced it down to 120. And they keep reducing the number. What they're finding is that people who are type 2 diabetics, if we can diagnose them early and help maintain their blood glucose levels, and they're good about maintaining their blood glucose levels, then we can minimize the long-term consequences and the complications. And so by catching people earlier, so the number of people are going up because we've reduced the blood sugar levels at which we call someone type 2 diabetic, but by doing so, it's reducing the long-term complications. That is the neuropathy, the visual issues, the cardiovascular issues. Again, the big deal is this high sugar really starts to abnormally affect blood vessel structure. So microvascular changes, so capillary changes leading to stroke and heart attack. Question?
Yeah, about the type 1 diabetes, the inadequate insulin production, it says here, is it that they don't produce it?
The beta
at
cells
all?
are destroyed.
Okay.
Now,
'Cause I feel like on the homework and stuff, it like keeps going back and forth between saying inadequate and like no production. And I just don't know. I just didn't know if that was something I was supposed to.
don't get caught up on that too much. The beta cells, I don't know what the threshold is, to be honest. Like, you know, there's so many millions of beta cells in your body.
Right.
I don't know at what point the number of beta cells is so low that the insulin is no longer effective and not working. But the consequence of type 1 diabetes is that the beta cells are destroyed. Full-blown type 1, there is no more insulin being produced. Now, guess what can happen to a type 2, though? A type 2 diabetic, their receptors are not working well. And over time, what's the pancreas actually doing? Overproducing insulin. And at some point, the pancreas just poops out and says, forget this. And so a lot of people, not all, but many people who don't have their type 2 diabetes well regulated may become type 1 insulin dependent because their pancreas just is so overworked, if you will, by having to overproduce insulin that at some point it says just kind of shuts down.
You said the thing about the coma with type 1 diabetes. How long does it take to die from not having insulin? Well, my sister-in-law's on a diabetic.
I do not know the answer to that. Anybody know clinically? Anybody deal with anyone type 1? Okay. I mean, I know it's...
Depend on the person.
It probably does depend upon the person, right? But you know, if they go into a low sugar situation, the problem is if they're alone, right? And they black out before they can help themselves out, then it can be a bad situation. That's the problem. Type 1 diabetics have to be aware of their own symptoms and be aware of their own, when their blood glucose levels are lowering, and don't take any chances. So if you feel like it's dropping, you know, take a lozenge, take some sugar.
What causes gestational
Gestational diabetes, okay, so that is sort of a third type of diabetes that is associated during pregnancy. All women are going to be screened with that lovely, what is it, orange or fruit punch stuff, right? And basically what they're doing is they're giving you a glucose challenge. If that glucose challenge comes back, if your body can't deal with that glucose well, then they'll do further testing. Women who test for gestational diabetes, typically when the baby's born, the diabetes, quote, reverses itself, but they are at rather higher risk for developing type 2 themselves. So it could be that gestational is basically type 2 diabetes hasn't occurred yet, but the onset of pregnancy sort of exasperates it, and many of those women will go on to produce or have themselves type 2 diabetes. So there's something still not right about the overall glucose regulation in their bodies, and the pregnancy sort of exasperates that. So again, what's the problem with diabetes? Retinopathy, right? Disease of the what? Retina. Again, a lot of microvascular structures, a lot of capillaries, and increased risk for heart attack. And again, the diabetic neuropathy. This is the tingling and the loss of feeling. And also kidney failure. Again, because of capillary structures. You know enough about the kidney to know the glomerulus, right? And all the little capillary structures of the kidney. Everything microvascular is at risk from high sugar. So kidneys, eyes, cardiovascular, you name it, nerves, all of these things are negatively affected by the high glucose. A person with type 1 diabetes really should have their feet checked often. If they start losing sensation in their feet, then they're not aware of pebbles or stones or something that's in their shoe. And because they don't have that sensation, they can actually get rather large ulcers where the foot gets ulcerated. The big wounds will open up and they don't feel it. And those can become infected and lead to a loss of limb as well. So amputation is another issue, another sequela of diabetes.
So when they say like diabetics have bad circulation in
Yep.
their lower limbs, it's because of the change in the blood
The high sugar over time destroys the capillaries and also damages the nerve. So you got two issues. You've got a issue with blood flow and issue with nerve, both. Usually more in the feet than the hands, but usually lower extremities.
So then not only can you not feel it, but your body has trouble healing it.
You can't feel it, and exactly. So you can't feel it. So if you do get a cut or a wound or an open sore, the body doesn't have the blood flow going there either to help restore it. So it's a double whammy. You don't have the normal blood flow. Yeah.
I was in a medical class at CGC in high school, and my teacher had worked in a foot place, and there was this little man that come in there, and then one time he came in there and they looked at his foot, and it had all holes, and they had to do surgery. Like,
Oh,
he
yeah.
was sleeping and he woke up.
They don't even know it. So diabetics need to be wearing white socks. Literally, they really should be wearing white socks because they can see the blood stain in a white sock more than a dark sock. They really should have a mirror next to their bed, so when they hang their feet over in the morning, they literally look down at the bottom of their feet to make sure there isn't damage to their feet. It's just a general routine that they need to become aware of. But those diabetic foot ulcers are amazing. They're a really cool area of research. But devastating for the patient, but a really, really interesting area of research or care. If that at all intrigues you, wound care is a huge field.
So is that like when you have diabetes and like my husband's grandpa has to have his toenails cut by a doctor? Is that because like if you nick your toe, it won't heal? Like why would you have to have somebody cut your toenails for you?
I think probably anyone could do that for that person, but the podiatrist would typically take on the role of that, doing the clipping. But again, you don't want anything that's going to irritate the shoe, or you want those
just
toenails
to
clipped
avoid
to avoid.
clipping your skin.
And that's why they also wear those big clumsy shoes, right? They're not tight. They wear the Velcro release on them. Just all those things are really avoiding any kind of tightening or potential damage to the foot because it's so sensitive to damage.
Because I work in a nursing home, and I know that, like, even though we're certified and everything else, like, we're not allowed to cut diabetic.
Yeah,
toenails.
yeah. They really poo-poo it, don't they? Yeah. Okay, so what causes more issues with diabetes, especially type 2, definitely type 2, is obesity certainly contributes to this. And I've already mentioned all the different opathies, right? The neuropathy, the nephropathy, what's that? Nephrotoxicity or nephropathy would be damage to the kidneys. Neuropathy, damage to the nerves. Retinopathy, damage to the retina and to vision. Okay, so that gets us really kind of through the hormone walk, okay, and a little bit more about type 1 and type 2 diabetes. Now, let me go into how hormones work together a little bit. We've only got about 4 little sections left. And as I go through this, I'm going to describe to you some scenarios, and I'll give you some examples. And these are the examples that I want you to appreciate. So there's 4 different ways that hormones interact with one another. Antagonistic, right? They work in opposite ways, opposing effects. Give me 2 examples. They're up there, but hopefully you can say these even without looking at these. What 2 yin-yang hormone combinations have we already talked about? Calcium, parathyroid and calcitonin, sugar, glucose levels with insulin and glucagon, right? Those are both opposing or antagonistic hormones. Do cells have receptors for both of these? Yes. Okay, I know we kind of get stuck in this idea that, one cell has one kind of receptor. Please, they can't draw it, but it's important to realize that a liver cell would have receptors for both insulin and glucagon, hundreds or not thousands of the receptors, and that these hormones have opposing effects. And so if there's more of hormone 1, right, than there is hormone 2, then hormone 1 would win, wouldn't it, overall? So these are antagonistic, opposing effects, and they oftentimes target the same cell. That's how they work, right? They're opposing the same cell doing the opposite. So here we just see the idea that hormone 1 is going to increase cellular activity, whereas hormone 2, different hormone, different receptor, but has the opposing effect internally.
Is there ever like parasympathetic, not every part of the body is affected by both? Is there also instances where there's cells that don't have receptors for both?
Yes, there are some. The question was, are there examples of cells that don't have receptors for both? Yes. But if it's an antagonistic effect, then we would say that the receptors on the same, both receptors are on the cell. Okay, in that antagonistic example. There's always going to be both there. Okay. Now, another way of hormones dealing with each other are additive effects. As the name suggests, there's summation going on. So this is where there's synergy, or where the hormones work together. Example, growth hormone is enhanced in the presence of glucocorticoids. Now, that's not an example we appreciate as much. I just want you to appreciate what additive means, right? When two hormones work together in synergy, doing sort of the same work, but even increasing that effect when they do things together. So here we see that hormone 1 and hormone 2, if they are both there, increase the cellular activity beyond what either one could do by themselves. Synergy. The third is permissive. Permissive effects. One hormone is needed for a second hormone to have an effect. Epinephrine will increase the rate of cellular energy consumption, but only in the presence of thyroid hormone. Okay, so this would be a permissive situation where epinephrine only does its work, only has permission to do its work if thyroid hormone is there. And when you hear about epinephrine, you hear about thyroid, what both come to mind? Thyroid hormone, increased thyroid hormone, you think of increased energy, right? Mitochondria, ATP, using up of energy. These two things, they're not synergistic, right? One is required for the other one to do its job, permissive. So here, hormone 1 only works if hormone 2 is there, or vice versa. Then there's integrative, okay? Integrative, the fourth type of interaction. And here, hormones produce different but complementary effects, not just totally yin-yang. And they are really, most hormones are integrative. In other words, there's a whole integration. All of these hormones are kind of working together at different times to maintain your overall homeostasis. So the example they're giving here is calcitriol. Calcitriol was mentioned briefly in the thyroid gland and PTH. Together, they work on calcium metabolism. They're not antagonistic. What was antagonistic to PTH? Calcitonin, right? Calcitriol is a different hormone, and they work, as if you will, to integrate all of calcium metabolism. So we didn't talk too much about that, calcitriol. In fact, I don't think I mentioned it at all. So that's just a little bit about how hormones can work with one another.
So integrative is like they do completely different things, but they kind of depend on each other at the same time?
Yeah, so integrative is basically different but complementary effects. So they're not both doing exactly the same thing, but they're both contributing to overall glucose metabolism, or they're all contributing to overall energy metabolism, but they're not targeting exactly the same thing. It's hard though, I think, to pull that apart from synergy, where they both work and do something together. So the line there is a little bit difficult to draw. Okay, just know there's 4 different ways that hormones work together. Okay, so now what I want to appreciate is that all of these glands are working together. The pituitary gland, the adrenal gland, the heart, the kidneys. I mean, there are cells and glands here that are regulating your blood pressure and your blood volumes. You know some of this, right? When I say heart and blood pressure, you're thinking ANP, ANH. When I say kidneys and blood pressure, you're thinking renin. So you've already been introduced to this back, long ago. So what I'm about to say to you is not surprising. Okay, it shouldn't be all brand new. And so we realize that these things are not working in isolation. So here is that whole story on ANH, natriuretic peptide, right? Made by the heart wall. And what does it do? It's released. We know this story. It's released when blood pressure is too high. Stretch receptors in the aorta sense that increased pressure and release this hormone. This hormone is going to go about trying to decrease blood pressure. And how will it do so? Give me some ideas. Tell the kidneys to do what? Right? Increase water loss. And how do how does anything get rid of more water? More sodium is also released. So it's going to increase the sodium flow and the increased water flow. It's also going to inhibit renin. Because what does renin do? Renin says, hey, blood pressure's not enough. Right? So we would want to inhibit renin, and we would want to inhibit ADH, right? Because ADH says what? Hold on to water, right? What do I want to do? I want to get rid of it. So I'm going to inhibit renin. I'm going to inhibit ADH. I'm also going to inhibit aldosterone. So we know that connection, right? And that was a difficult question on the exam, quite honestly, to grade. Many of you did very, very, very nicely on that question about the interaction of those four hormones, right? So most of you were well prepared for that. It was difficult because there's a couple different ways you could have approached it. Most of you sort of divided up the conversation into sodium high and low, blood pressure high and low, and kind of talked about those two different scenarios, and you did a beautiful job on it. And so I was very pleased with that. But it's a really important hormone control that we understand: renin, aldosterone, ADH, and ANH. So, there's a beautiful little picture, right? Maybe you should have used that one, right? We weren't on this chapter at the time. But this one kind of pulls it all together and describes increased blood pressure, blood volume, and how the heart ANH, the natriuretic peptides, are going to help reduce that pressure.
So if you have chronic high blood pressure, are your baroreceptors not working?
They have given up. Baroreceptors are good for temporary influence. So when you stand up and all of a sudden blood rushes away from your brain and away from your heart for a moment, those baroreceptors kick in and help with your blood pressure. But long term, they no longer are very effective. So if you have chronic high blood pressure, clearly the baroreceptors are no longer doing their job. Yeah. So what else? Okay, so we've talked about renin, but we did not talk about this semester EPO, erythropoietin. EPO is also made by the kidneys, a little bit by the liver, but mostly the kidneys. And what does EPO do? We talked about this a little bit in 105. Red blood cell production, right? It's increased red blood cell production. And if you increase red blood cell production, you're also going to be increasing blood volume, okay? It's not majorly, but definitely it contributes to it. And then renin, again, is going to increase your blood pressure, and it activates that RAAS system, that renin-angiotensin-aldosterone system. I've alluded to that. We're going to come back and talk about this RAAS system at length again when we get to the respiratory system, and we'll see how the lungs are involved with this, and talk about how the kidneys and the lungs work together to do this renin-aldosterone angiotensin story. So we're not done with this one. You're going to hear this again. So we got a little bit about EPO, a little bit about renin, and how it regulates your blood pressure. And again, that's all shown here for you. You know this story. What you do not know in this thing is simply the EPO. So there's a mention of the EPO right here, okay? But the rest of it you've seen before. We've also got a lot of homeostatic regulation of growth. Growth hormone, definitely. But also think about energy. Glucagon and insulin are also involved with your overall growth and energy production. Thyroid hormone was definitely involved with energy production. And they're all working together to help change and contribute to your growth patterns. So let's see how these guys go together to think about growth. Insulin, right? Insulin is definitely going to allow for your cells to take up glucose. PTH, calcitriol, and calcitonin are all what? Related to calcium regulation. What did we say about PTH? It's released when calcium is too low. So what is it going to do? Promote bone deposition. That is, it's going to do what? Promotes absorption of calcium salts, right? So it's going to increase, it's going to help increase the calcium. Calcitonin, we know, is going to be released when we are calcium's too high, right? That's going to increase your bone deposition. And you need all these, right? You need insulin. We don't think about it, but you need insulin also to help with your bones. Typically, we just think of PTH and calcitonin, but insulin's also important. Thyroid hormones, reproductive hormones. We didn't talk about reproductive hormones this time around, did we? We mentioned them. I said that you have the gonadotropins. They are affecting the gonads, but we really didn't go into much of that. We'll talk a lot more about the estrogen, progesterone, testosterone story when we get to the reproductive system at the end. I should go back, though, and just highlight this. I think everyone knows this, but reproductive hormones, especially estrogen, definitely have an effect on bone, right? So postmenopausal, right, when estrogen levels are low, then women have issues with bone density, don't they? So they do some estrogen replacement therapy to HRT, hormone replacement therapy, or estrogen replacement therapy to help counter that bone loss. So clearly the reproductive hormones are not just about maintaining, reproductive function, but are also doing a lot of other things as well.
Is that to like prevent osteoporosis?
It does. So women who take hormone replacement therapy are trying to slow down the osteoporosis. Without estrogen, you don't have the proper bone maintenance.
Why do men not have bone issues as much then? Because they have lower estrogen.
But they do have lower estrogen, but it's continued to be made. So estrogen is made in men at a steady state. Just like women, men make most of their testosterone through the testes, but very little in their adrenal glands, but a little bit there. Women, that's their only source of testosterone. So I think the deal is that the estrogen in males, testosterone belongs to the same family, and testosterone can help with bone and blood production and helps maintain it better. Low T, right now, all the commercials on low T and low testosterone levels, part of it is bone density and muscle strength and libido, all those things that testosterone contribute to. So I think it's just because the guys keep cranking out testosterone that the bone is maintained better than in women. Yeah. So where do we see these hormones being produced? I just want you to realize some hormones are produced greater in childhood, some more during puberty, some are maintained higher levels throughout life, some drop with time. So just appreciate that hormones are released at different times during the body's life cycle to increase bone or to maintain nervous system development. What does growth hormone do? In children, growth hormone is really important. Right? You need growth hormone at rather high levels to maintain growth of bone and muscle. But in adults, we don't need growth hormone for the purpose of growing longer bones or more muscle. Now we use growth hormone to assist in energy metabolism. So we see there that the hormone actually changes its purpose, right, in life. There's a little chart about that. Okay. And then the last thing I want to describe to you is stress responses, and then we'll jump over to some review stuff. So the stress response, now I had a student remind me that the homework for this chapter was due yesterday, right? And you didn't get a chance to do this. And I think there were two reasons for it. I just want to justify it in my own mind. One was I wanted you to have the chance to do the adaptive follow-up afterwards. So if you didn't quite get it, have a chance to do that before the exam, and that's 2 days out. But also, and have it done before the quiz, right? So that means the quiz is due when? Tomorrow night?
Yep.
And in order to have the quiz done, have the homework done before that, you had to have the homework done 48 hours before. So it's kind of a domino effect backwards. I also want you to come in here as well prepared as possible, which would kick you into doing that homework early, just to see where your deficits are. So you can talk to me about where you're not understanding things. Maybe having heard some things, or what I'm about to talk about, will make more sense of the stress response. Okay, because I looked on the quiz, or I looked on the homework, and there were a couple questions about this that were some of the lower correctly answered questions. So let's see if I don't solve some of those problems now, and if not, we'll talk about it. So the stress response. So what's going on? We're stressed, right? We all say we're stressed, but here I'm talking about really extreme situations where your homeostasis is really drastically affected. Now, what can lead to stress? There are whole lots of things it can do, but some sort of stress response, or what's called the general adaptation syndrome, how your body adjusts to stress. Now, in stress, there are 3 phases. The first phase is the alarm phase. It's basically, hey, something's going on. It's here that you have that immediate sympathetic surge, right? So immediately, a little bit of sympathetic surge, and that's going to basically be epinephrine released from where? The adrenal medulla, right? And that is going to do what? What does adrenaline do? Fight or flight? It's going to cause your body to make more sugar available, right? It's going to cause your glycogen levels to be broken down a little bit, and it's going to put you in that fight or flight response. That is, again, sympathetic stimulation, sympathetic stimulation, adrenal medulla, release of epinephrine. We get it, okay? Fight or flight responses. We know what happens. You know this, especially from your autonomic nervous system preparation, that at this point, you become more mentally alert. You're going to release more energy from your cells. You need that energy to do things. You're going to mobilize more of your fat reserves. You're going to increase your heart rate. You're going to decrease your digestive function. You're going to increase your sweating, and you're going to increase your respiratory and cardiac rates. We get that. That's what happens when the bear is chasing you. Now, from the alarm stage, we go into the resistance stage. This is a longer term. This is after a few hours of stress. Now, honestly, how many of us are, when you think about being chased by a bear, you think, okay, the bear just came on the campground, I'm going to run. We're not talking about hours later, right? But that's a quick alarm and it kind of is over. But here we're talking about something that has been sustained and is causing some stress. And a few hours after that alarm has gone off, now we're going to go into a resistance phase. Here, epinephrine is no longer the dominant hormone. Now it's glucocorticoids. Now the glucocorticoids were made by what layer of the adrenal cortex? GFR, salt, sugar, sex, right? So the sugar glucocorticoids are made by the fasciculata, right? F. And here, those are the major hormones, especially cortisol. That was the one hormone I told you was the glucocorticoid that I wanted you to know as an example. Yes, epinephrine, yes, growth hormone, yes, other hormones are involved, but that's the big one. During this resistance phase, you're still trying to release energy, right? You're still trying to get energy, but at some point, the glycogen reserves will get exhausted, right? There's only so long that you can crank up the need for your body to have energy, and you're going to exhaust those levels of glycogen from your liver. And the body is going to shift from using up the sugars to starting to use up fats and using up amino acids. Overall, you're basically just getting energy anywhere you can, and you're also trying to reserve glucose. Because what did I tell you? The brain only uses glucose. So during this resistance phase, the body's going to start trying to break down proteins. It's going to start breaking down fats. It's going to have what's called a glucose sparing effect, because you need that glucose for nervous tissue. And so, little chart about that, okay? And again, what are the hormones involved? What did I tell you? Glucocorticoids. What's going to turn on the glucocorticoids? ACTH, right? So that sympathetic surge is going to turn on not only epinephrine, but it's also going to turn on the hypothalamus and the anterior pituitary to make ACTH. The ACTH is going to come down to the cortex. It's going to make more of those glucocorticoids. The body's also going to be trying to, right, release more glucagon. What does glucagon do? It's released when blood sugar levels are too low, so it's trying to increase sugar. What cells made the glucagon? Alpha cells, right? So the alpha cells will be upregulated during this resistance phase. Growth hormone will also be involved, trying to get some energy stores available. And ADH will also be involved a little bit here. And then finally, after you've gone through the alarm phase and the resistance phase, at some point, pretty much the energy levels, the energy reserves have been depleted. The body has done everything it can, and at this point, the resistance phase ends. This can be weeks or even months. At this point, the body can no longer maintain homeostasis. Organ systems begin to fail. Mineral electrolytes, right, are all out of balance. Now, if your sodium and potassium and calcium are out of whack, we can only imagine the effects it would have on your nervous system. You can no longer fire off action potentials properly. We'll learn in the next chapter you no longer can contract your muscles properly without those electrolytes in the right place. So at some point, all of this balancing act of sodium potassium pump and all the things we've been talking about breaks down completely. And death is the result of this. Now, I want you to think about people you know. We don't think about people going into exhaustion phase and dying as a result, because in this part of the world, what normally happens before someone reaches that exhaustion phase? Someone comes along and helps them, right? Someone is not going to maintain themselves in that resistance phase for weeks or months, usually without some sort of intervention. But I always think about that resistance phase. I know a lot of single moms, a lot of single parents who are kind of in that chronic resistance phase. Think about a soldier, right, who's in the trenches and they're in that constant, alarm phase. I mean, way beyond alarm. They're in that resistance phase. Now, they have hopefully some support, right? They got some nutrients and some other help. But if you're in a real war situation, in a combat situation, you can imagine that the body would get to this exhaustion phase, and it can completely whack out someone's nervous system and their muscle contractions. Okay, so just know the 3 phases of the alarm system. Definitely some hormones involved with that, the 3 phases of the stress, and there's definitely some hormones involved with that. Okay, and then the last little bit are some endocrine disorders. I'm going to just flash through them quickly. These are the disorders that occur when some of these hormones are high or when they're too low, hypo or hyposecretion of these. So you recognize that every hormone needs to be at the right level, right? There's a homeostatic level, there's a set point. These hormones work within their normal levels, but if a gland does over or underproduce these hormones, there can be rather significant clinical consequences. If there's hyposecretion, as a general rule, hyposecretion is going to do what? There's going to be a deficiency, right? Typically, there's going to be some sort of deficiency. So what if you had an inadequate amount of iodine? If you don't have enough iodine, then your body can't make enough thyroid hormone, T3, T4, and you would be said to have hypothyroidism, right? Low levels of thyroid. And what would you expect your symptoms to be? Hypothyroid? Low energy, low metabolism, right? Maybe some weight gain, absolutely. There could also be congenital disorders. So something you're born with, just the way it is, if you will. And the gland could be too small. The gland could have an enzyme missing that's necessary for something to be made, a hormone to be made. Receptors that are insensitive for some reason, or the gland doesn't have the receptors to get stimulated in the first place. Ooh, I want to ask that question too. Sort of as an aside, but it kind of pulls it all together. Transcription and translation, right? When I say there's enzymes missing, right? Genes code for proteins, right? So that means, do you have a gene for insulin? Insulin's a protein, so you have a gene for insulin. If that gene was defective in some reason and you had defective insulin, then you might have basically the effects of diabetes because you have a funky insulin, right? It doesn't work quite as well. Could you have a gene for ACTH? Or do you have a gene for ACTH or for growth hormone or for FSH, LH? What do we know about those hormones? All of those hormones are peptide hormones. So they too are made of protein. So there are genes for those hormones. What about testosterone? Is there a gene for testosterone? They're steroids, right? So do genes make fats? Right? Genes make proteins, right? Transcription and translation make proteins. So there would be many enzymes that take cholesterol and convert it into testosterone. And those enzymes are proteins, so they would be made, there would be genes for those. But there is no, quote, testosterone gene. There is no, quote, estrogen gene. There are many enzymes necessary to make those molecules in your body. Does that make sense? I think that's an important little aside. So when I say there's something wrong with the enzymes, required enzymes are abnormal, that would especially be for steroid hormones, but not all of them. So again, you could have metabolic issues, you could have damage to the gland, there could be something you were born with, some congenital disorder. So type 2 diabetes is a good example where the peripheral cells, the cells that have the receptor, do not respond to the insulin. So there's an issue with the receptor. And that's not that uncommon, but diabetes type 2 is a good example of that type of relationship. Now, I've already mentioned acromegaly. What's acromegaly? Talk to me. We talked about this back in the bone chapter. This is Shrek, right? Fiona and Andre the Giant. What happens? This would be an overproduction of growth hormone when? After puberty, after the growth plates have closed. So there's no longer going to be lengthening of the bones, but there would be changes in the hands, the lower jaw, big, broad facial expressions, and there might be some cartilaginous changes of the skeleton that enlarge, but the skeleton itself can't change in height, but there might be some bone changes. So you see this very pronounced lower jaw in this individual. That's not the best example, right? They just need to put a picture of Shrek there. Now, a goiter, right? We don't see goiters in this country anymore, for the most part. This is a very enlarged thyroid gland. Goiters, big structures of the neck. Usually because the thyroid gland is hyposecreting because there's a deficiency in iodine. So iodine deficiencies were historically the major reason for goiter. If you had hypothyroidism, you would also have what else? Again, low energy levels, right? But there are also examples of infantile hypothyroidism, a congenital situation where the thyroid gland just does not work normally. And these individuals are characterized, this is interesting, the thyroid gland, if you're born with a low thyroid, contributes to intelligence, right? So these people usually have some sort of mental disability. Why might that be? Put that together as a hypothesis. Put that together. Why would hypothyroidism from birth throughout development perhaps, and it does, lead to mental disability? Mitochondria, right? So you've got low ATP, you've got low energy throughout development. And if you don't have enough energy throughout development, that's certainly going to have an effect on some very important structural things, including the nervous system production. So there's a goiter, pretty classic picture, big old swollen thyroid. This is also the infantile hypothyroidism, and it mentions in the characteristics a big swollen tongue, right? Kind of looks like a Down syndrome, big tongue sort of situation. Addison's disease, this is an issue of the adrenal. So Addison, adrenal, this is hyposecretion of some of the corticosteroids, especially the glucocorticoids. And this also usually has some pigment changes because there's also that melanocyte stimulating hormone that's kind of connected into this, that's stimulated by ACTH. There's Cushing disease, this is a hypersecretion. So here's the two different conditions. Addison's, low levels, Cushing's, high levels of glucocorticoids. And here, the Cushing's disease, because you have a high level of glucocorticoids, you're always mobilizing your lipid reserves. It leads to an enlargement of the cheeks and to the base of the neck. So sort of a big, a lot of fat reserves around the neck region. Back here, the pigment changes. This would be a little bit of Addison's disease. It's not that noticeable in this picture, but there's some pigmental changes on the face. Again, that'd be hyposecretion. And then here is the big puffy kind of cheeks and some of the fat laying down in the neck region, and that would be a picture of Cushing's. I'm not going to show you 10 pictures and say what disease they have, so don't worry about that. Here are, again, some other diseases that I've already mentioned. What if you don't have growth hormone or ADH, thyroid, parathyroid. There are people with decreased levels of ADH. Right? Their hypothalamus doesn't make ADH. What would be their problem? If you're not making ADH, you got a problem with hydration. What are you always doing? You're always peeing and you're always drinking, right? So this is another form of diabetes. People who have another form of diabetes called diabetes insipidus. And this is a situation where they just pee 20 to 30 gallons a day. Constant peeing, right? Not the diabetes related to sugar metabolism. It's a completely different condition. But in those conditions, because ADH is not there, it could be a late onset. Typically it is. But they have diabetes insipidus. Okay, they have polyuria, tremendous dehydration, tremendous thirst.
So that could cause death just from people being so dehydrated?
It can. They typically just keep drinking. Their body drives them to drink, and they're constantly urinating. I can't imagine life like that.
That's not very common.
No, it's not very common. No. And I don't know, honestly, I don't recall if we now can give them some ADH to help slow down that system, that problem.
Like a supplement?
Yeah, like a supplement or some sort of injection, yeah. So definitely the ones that I've talked about, know those over and under productions. This little table kind of goes through that with you. And again, make sure you know the hypo and hypo secretion of these hormones. Now that brings us to the end. That's a lot of stuff, isn't it? Fair enough amount of stuff. So I got about a half hour to sit here and just kind of talk with you. And you might want to grab your yellow form if you have that, and let me know if there's areas of that yellow form that are giving you trouble. And I'll also quiz you on a few things before we even get started there.
I have a question.
Question?
If we're hybrid,
If we are hybrid,
yeah,
okay.
and and I think this is handed out on a Thursday.
It was in the lab.
Yeah. Oh, and
I gave it out to Thursday for the hybrid lab students, and I gave out in lecture last Thursday in lecture, and then it's also posted.
okay, it's posted.
It is posted, okay?
That's
But
what I
my normal hybrid students are in Thursday lab, so they all got it last Thursday in lab, and then I brought it to Thursday lecture.
Which I
Should have
haven't
caught
either of
everybody.
those, so.
I should have caught everybody at that point, and then it's also on Blackboard,
Okay.
okay?
I just didn't know if everything was.
Yeah, most everything is, I'm going to try to post things, but I want to be, I'll give you copies of important things. I want everybody to get that page. Okay, so talk to me. I'm just going to say the gland, and you tell me the hormones produced. Let's just start it there. Hypothalamus. ADH and oxytocin. ADH and oxytocin are both released by the hypothalamus and are directly dumped into the posterior pituitary. What is the structure? What's the arrangement? How is it that those hormones go from the hypothalamus down to the pituitary, posterior pituitary? There is a neuron-like structure. So these hormones are actually released like neurotransmitters from specialized neurons in the hypothalamus that dump basically into the posterior pituitary. And it's from there that those hormones are released. What is that connection called? Hypothalamus hypophyseal shunt or portal system, right? And that is how those hormones go directly from the hypothalamus to the anterior pituitary, or in the posterior pituitary. Now, when I say anterior pituitary, let me go back. What else is made by the hypothalamus besides ADH and oxytocin? Those inhibiting and releasing hormones, okay? Of which there's 5 or 6 of them, okay? But if you see inhibiting or releasing in its name, you know it's hypothalamus. Now, let's go to the anterior pituitary. 7 hormones made there. And you should be able to kind of rattle these off in your head. Not that I'm going to ask you to write this all down, but you should be able to appreciate these hormones. Name them off for me. FSH and LSH. Those might be called gonadotropins, right? Because they affect the gonads. Then there's TSH, ACTH, growth hormone, and prolactin, right? And also melanocyte stimulating hormone, which I told you is really not effective in you as adults. So we kind of put it off to a separate little category. It is made, it's important for melanocyte activity during development, but as an adult, it's really not made anymore. The other 6, though, still are very much involved and are regulating and released all the time. Now, let's go to the thyroid gland. Thyroid hormone, 2 flavors, T3, T4. Okay, we won't go any much deeper than that.
Do you want us to know like the thyroxine and the triad?
Well, tri is T3,
Yeah.
Okay.
right? The triionated,
Yeah.
that's the T3, tri. If you see the word, you'll know tri is 3.
Okay.
Okay, but T3 or tri, T3. What else is in so thyroid hormone, but also calcitonin, and what cells make the calcitonin? C cells, good. And back on the back side, we've got the parathyroid gland, and it makes parathyroid hormone by what cells? Parathyroid or chief cells. Another C, unfortunately, right? Chief and C cells, but chief cells or the parathyroid cells. We already know that story, but I'll say it again, though. Calcitonin released when calcium is too high. Parathyroid released when calcium is too low. Let's go to the pancreas. About 1% of the volume of the pancreas is involved with hormone production. Those clusters of cells that make the hormones are called the islets of Langerhans, or the islets. And within the islets, there are at least 4 different cell types. The 2 big ones, alpha and beta. Alpha is producing glucagon, whereas beta cells are producing insulin. Those 2 hormones would work together in what we would call opposing or antagonistic ways, and they're both involved with glucose levels. Glucagon is released when glucose is low. And what will it do? Glucose is low, so it's going to scavenge the body for sugar. So it's going to go to the liver and tell the liver to break down glycogen into the sugar and release it into the bloodstream. If instead sugar is too high, then the beta cells will pick that up, signal it, and will do what? Secrete insulin. Insulin then goes throughout the bloodstream and basically reports to most of the cells of your body that, hey, there's a lot of glucose out here, let's go ahead and eat it up. So it tells the cells to do what? Open up or increase the absorption of glucose. There's also F cells and delta cells there, but they're not as important. Definitely know the alpha and beta cells. What are the 3 phases of the alarm, the stress? 3 stress. I just did that, right? First one, alarm. Mostly what hormone? Epinephrine. This is the sympathetic surge. Then after a few hours, then we go to resistance, and now we're dealing with still releasing energy, but we're going to increase the amount of ACTH. And ACTH is going to travel down to the adrenal glands and do what? Increase cortisol. Cortisol was that glucocorticoid. And what's that going to do? Part of what it's going to do is we want to release energy, but what do we not want to break down? We don't want to break down all the glucose in the body. Why? Because the brain requires glucose. So in this long-term resistance phase, we want to start targeting fat breakdown and protein breakdown.
So that's why when people are stressed, they lose weight.
I need more stress in my life. Because Stacy just said, that's why people, when they're stressed out, lose weight. Clearly, I am stress-free. Okay. I must be doing well. I don't know. More stress, please. But yeah, typically you will say that a lot of people will lose weight when they're really, really stressed out. Or stressed out can do what? Make you eat, right? Or make you eat. So it depends. Some people respond differently to stress. And then lastly, right, you go into the fatigue or exhaustion phase where you pretty much you've really wanked out all of your homeostatic mechanisms, your electrolytes are out of control, your sugar's out of control, and you're going to die pretty soon. Okay, and again, we don't get there very often, but it can happen. It can happen. Yes, ma'am.
I did have a question about stress.
Yes.
Now there's
Physiological.
thank you, stress, and then there's mental stress.
Yes.
And both have the same.
They both can do the same thing. So if you're mentally stressed, you will definitely increase more epinephrine, your heart rate will go up, all that's the same. It can, over time, lead to cortisol release. And yeah, some of the same sequences can occur.
Okay, mental stress is common here. What is a common physical stress?
I would imagine they go together, but I'm thinking, say it again? Yeah, physical labor. I'm just thinking situation, right, which is mental and physiological. So, not enough food, poor housing conditions, anything like that, honestly could put you both over mentally and physiologically and put you into that kind of resistance phase.
So if you had anxiety, would that mess with that too?
Mm-hmm.
Increase the resistance?
Mm-hmm. Yep. All that. So people who are just always anxious, all those things can definitely a lot of people are in resistance phase, right? But at some point before death, right, we collapse and we get some help, right? Someone comes along and helps you out and changes the situation. Okay, so I've kind of gone through a quick thing on the hormones. You guys did really well with that. So look over your yellow form. Is there something in there? Remember that on the test there'll be 2 Venn diagrams. If you listen to the autonomic nervous lecture, at the end I kind of mentioned this. There will be 2 Venn diagrams. You've seen these with me if you took me for 105. And those Venn diagrams will look something like this. And one circle will be sympathetic and one circle will be parasympathetic. And on the test, I would have a list of facts down here. There'd be fact number 1, fact number 2, fact number 3. If the fact had to do only with the sympathetic nervous system, you would bubble in A. If the fact had only to do with the parasympathetic, you would bubble in B. If it involved both, you would bubble in C. And if it affected neither system, you would bubble in D for neither. And there's about 10 or 12 facts that are like this on the test. It's all up on your bubble sheet. There is no short answer on this test. But there will be a Venn diagram similar to this. And there'll also be another Venn diagram comparing and contrasting the nervous system and the endocrine system. So let's talk about that. Throw out a fact for me about the nervous system, and then tell me how the endocrine system does it maybe a little differently. Yeah. So the nervous system, they both work through chemicals, right? In the nervous system, those chemicals are called neurotransmitters. They're released by neurons at very discrete, localized locations. Whereas the endocrine system releases instead hormones into the blood. Those hormones are traveling throughout the body and are only going to be picked up or detected by tissues that themselves have receptors for that hormone. What else? Endocrine versus nervous. What about timing? Any issues on timing you can think of? Yeah, endocrine's a lot slower. In fact, let's expand on that. Endocrine is slower, nervous is faster. What did I tell you about the half-life of hormones? What kind of hormones had a longer half-life? Those that were carried or those that were freely floating through the blood? Those that were carried. And the ones that are carried are primarily steroids and thyroid, right? So those hormones are going to have a longer, quote, half-life. They're going to float around longer, be more protected. Their effects would be longer lasting, harder to get rid of them. Protein hormones, peptide hormones have a shorter half-life. They're destroyed within the bloodstream, and their effects would therefore last a shorter amount of time.
But it's still longer than.
Still longer than the nervous system, but shorter than steroid-like hormones.
Is that why when somebody does steroids,
Yep, anabolic steroids. Why are they injected? Why can't you just swallow them? Why are all these anabolic? Why do you guys have to, shoot up with guys and gals, right? Why do they have to shoot up with anabolic steroids? Yeah, they're just not absorbed well. They're not absorbed well through the GI tract. So it's really more of just a problem, right, of getting them absorbed into the gut. But yeah, they need to be injected directly. What else? I'm looking at your packets from across the room. What's on there? What's the second question? Compare and contrast, parasympathetic and sympathetic. Talk to me about that really quick. Sympathetic? Okay, let's go there, right? So the sympathetic, what do we remember about this? Let me clean this screen. Sympathetic. That sympathetic nervous system is called the what? Thoracolumbar. Why thoracolumbar? It's only come from the thoracic and the lumbar regions, nerves. And there's two neurons, right, in all these systems of the autonomic nervous system. There's a pre and a post ganglionic neuron. Now, the ganglion is what? Cluster of cell bodies found in the peripheral nervous system. For the sympathetic nervous system, where are these ganglia? These little clusters, these little... Yeah, these are the paravertebral. Many of you missed that on your nervous system exam, lab exam. Right? There was a sticker on one of those, and those are those little pink gems, if you will, going down the side. Here's your vertebra. And on either side were those paravertebral ganglia, or those sympathetic chain ganglia. Now, let's think about it. The neuron is leaving from the thoracic and the lumbar region, and the first neuron only has to go from the spinal cord out to the ganglion. That means that the first neuron, the preganglionic cell, is rather short. The second neuron will be much longer, right? Let's say it's going to the heart, okay? And what would that be doing? Sympathetic would be going to the heart to tell it to increase, okay? So that's the sympathetic thoracolumbar. What else do we remember about the structure here? The preganglionic fibers, these are all myelinated or unmyelinated? Myelinated, okay? Always myelinated here.
In both systems.
In both systems. And what do we know about the sympathetic nervous system? Lots of, what am I drawing here? Lots of divergence, right? Lots of neurons talking to other neurons. And so there's a lot of spreading, right? A lot of divergence in the signaling. Now, the second neuron, the postganglionic, much longer and is unmyelinated. How does this compare, though, with the parasympathetic? I'm going to change colors, okay? See if I can do this. Parasympathetic was called the what? Craniosacral. Why? Cranial nerves and sacral nerves. Which cranial nerves are involved with the parasympathetic nervous system? 3, 7, 9, 10. Right? 3, 7, 9, 10. What are those cranial nerves doing here? What is number 3 doing? Think parasympathetic, rest and digest. Number 3 is the ocular motor. What is it doing? Constricting the pupil. So we know when we're resting, right, our pupil is more constricted. So that's what that one's doing. Number 7 and 9, facial and glossopharyngeal. We know these are both about taste. If you're rest and digesting, you better be making saliva, getting ready to have that lovely meal. So that's how I remember that one. 7 and 9 are involved with parasympathetic. Number 10, vagus, also a little bit of taste way back in the epiglottis, but also involved with slowing down your heart rate and increasing your digestive. Now, how do these little nerves work? Where is their ganglion? Parasympathetic preganglionic neuron, relatively long. Why?
'Cause
The parasympathetics don't go to the sympathetic ganglia, right? They go instead where?
in the wall.
Yeah, so parasympathetic, the first neuron, here's the spinal cord, coming down from the cranial nerves or from the sacral nerves. The first one's very long. Where are those sacral nerves going, for example? Digestive, bladder, urinary function, right? Reproductive function. And they have a very long preganglionic. The ganglion is near or within the wall of the organ, the target. And so that makes the second neuron very, very short.
What was the name for that?
Intramural. Intramural. So intra within, mural wall. Intramural. So terminal or intramural. So near the end, almost at the organ and within the wall of the organ itself. Now, let's say this is the 10th nerve, right? Vagus nerve. It's coming down from the cranial area and it's going to the heart. Where is the ganglion? Right before or within the wall of the heart. Right? So that's why the preganglionics are very long fibers and the postganglionics are very short fibers.
So then it's sympathetic is divergent, so it's
Parasympathetic is more discrete, not as divergent, which is why I always remember it this way. Sympathetic, all points are alerted, right? Heart rate goes up, respiratory rate goes up, hair goes up on your skin, you become more pale. All those things happen pretty much all or none. You don't have much choice. They all occur at the same time. Very divergent. Signals are sent everywhere. Parasympathetic's involved with rest and digest, urination, defecation. Those are all things also. They're sort of in that rest and digest mode. And you certainly don't have to do both of those at the same time, right? You don't have to urinate and defecate at the same time. From a reproductive standpoint, what does the parasympathetic nervous system do? From a reproductive standpoint, what does the parasympathetic system do? It allows for blood flow and erection. What does sympathetic do? Ejaculation. Now that's one of the few examples where sympathetic and parasympathetic are both involved in a function. Usually, typically, they are antagonistic. Heart rate goes up, heart rate goes down. Respiration goes up, respiration goes down. But in order for ejaculation, for erection and ejaculation, that requires both sympathetic and parasympathetic working together in a cooperative way. So when Stacy asked about the divergence, right, the parasympathetic is not as divergent. It is more discrete or more localized. Again, it sounds kind of crude, right? But you don't have to ejaculate and pee, right? Or ejaculate and urinate. You have choices over these things. They're more discrete. They're more localized. It's not an all or none phenomenon. Okay. That'll help you remember that. What else about sympathetic, parasympathetic? Sympathetic, parasympathetic. Anything else that comes to mind?
like about how they don't always both affect organs.
They don't always both affect an organ. Typically, we think of antagonistic, but what is one example? I think it showed up in the quiz somewhere, right? About blood vessels. Sympathetic, well, let me ask it this way. How is it that blood flow when the bear is chasing you, right, sympathetic, why is it that blood flow increases to your muscles but decreases to your bladder? Decreases to your kidneys. It's all a difference in constriction of blood vessels, right? The smooth muscle. So what does that tell you about blood vessels? Blood vessels to your kidneys, right, are going to constrict during a sympathetic, whereas blood vessels to your muscles are going to dilate during a sympathetic surge. The difference is not the hormone, right? It's still epinephrine. What must be the difference? Why do some blood vessels dilate and why do others constrict? The receptor type. Okay. So now, okay, so up until now, I haven't got into this conversation, right? But up until now, what have I said? There's a little bit of the autonomic nervous system presentation. But typically we think, okay, insulin receptor. Right? But there are other hormones where the receptor is quite different. So epinephrine can be seen by some tissues as excitatory and as other tissues as being inhibitory. Why? Because of the kind of receptor they have. Same hormone, different receptor. Different receptor, different effect. So sometimes the effects can be excitatory, sometimes they can be inhibitory.
Is that like how all like pharmaceutical drugs work then? It all has to do with receptors?
Those beta blockers and alpha agonists and all those different classes of drugs that some of you will be learning about, a lot of it have to do with affecting receptor types or interfering with receptor types, right? So it interferes with, and therefore the whatever that process in your body can't occur. Yeah. Other question?
What is the receptors that are in AMS, like the alpha receptors and the
Okay, so let's talk about this. Did I go into nicotinic and muscarinic a little bit? Okay, so these are really unfortunate names. They really are. Nicotinic receptors were first found to be excited by nicotine, okay? And so they were called the nicotinic receptors. And the muscarinic receptors were first found to be involving muscarine, which is a mushroom extract. So in the lab, these things were found to be true, and as a result, the name has stuck. So we have nicotinic and muscarinic receptors. What do the nicotinic receptors do? What do they respond to? Let me go back. In fact, let me go there with you, okay? Because this is always an area of confusion. And I think if I spend the next 5 or 6 minutes looking at this with you, it'll clarify this. Because I forgot, to be honest, that this was part of that autonomic nervous system. And it is on the test. And I want to make sure that you're clean with this. So I'm going to go back to lecture materials, and I'm going into chapter 14. And I'm just going to go to that little conversation about the receptors, because I think it's an important one. Starts off by just going through what we talked about, the different types of nerves, the location, what's different about them. Now here we go. So we're 14-5, 14.5. And neurotransmitters released in the sympathetic division. The receptors are adrenergic receptors. What are they responding to? If you're an adrenergic receptor, you're responding to adrenaline, right? So adrenergic receptors respond to adrenaline. And there's two types, alphas and beta. So there's alpha and beta receptors. Okay? Cholinergics are going to be responding to acetylcholine, right? So adrenergic receptors respond to adrenaline. Cholinergic receptors respond to choline, acetylcholine. Now, in this story, neurotransmitters bind to adrenergic receptors. Again, what is it? Adrenergic receptors are adrenaline, right? So epinephrine and adrenaline are the same thing. I wish they would keep the names straight. But norepinephrine will stimulate alpha receptors more than beta receptors, whereas epinephrine will stimulate both alpha and beta receptors equally. How does this work? Why do we care about this? Basically, under sympathetic activity, you're releasing both norepinephrine and epinephrine from the adrenal medulla. They're going to affect both the alpha and the beta receptors in the body, but in your body, you release 3 times more epinephrine than you do norepinephrine. Okay? And as you know, when these hormones are released, they stick around for a while. So these hormones are going to be affecting these different receptors. Now, what do these receptors do? Think about it, and you know this. The alpha receptors are stimulated by both, and they are going to be triggering different things. Typically, alpha-1 receptors are excitatory, alpha-2 receptors are inhibitory, and that's fine for you to remember that. So alpha-1 excitatory, alpha-2 inhibitory. Whereas, and that shows you here, so here's norepinephrine. It comes in, it hits an alpha receptor. That alpha receptor, right, if it's an alpha-1 receptor, will cause an increase in something. If it's an alpha-2 receptor, it will instead cause an inhibition. General ideas. General ideas. Some medications are alpha-2 inhibitors or alpha-2 agonists. They're going to increase or decrease the effects of these physiological responses. Beta receptors, okay, beta receptors are generally stimulated by epinephrine, and when you think about having a sympathetic surge and the bear is chasing after you, these are largely the beta receptors. What do beta receptors do? They cause an increase in blood pressure. They cause an increase, especially blood pressure, right? So people who have high blood pressure might be put on a beta blocker. So what's it doing? That medication is causing a blockage of these beta receptors. And now the body will not as easily increase the blood pressure. Okay? So that's what this whole, when you hear about alpha blockers and beta blockers and different classes of medications, I know we're not there. You'll get more about that in clinical studies and in pathophysiology. But that's what they're talking about, blocking or increasing the activity of these different receptors. So here's epinephrine. It comes into the beta receptor. And the beta receptor now, if it's a beta 1, it typically will increase cardiac muscle contraction. If it's a beta 2, it'll cause changes in skeletal muscle. If it's a beta 3, it'll release adipose tissue. I'm not too concerned about that, but overall, beta is all about increasing sympathetic activity. Now, that is what I want you to know from the sympathetic side, right? You've got adrenergic receptors, alpha or beta. Alpha were what? Alpha 1 were excitatory, alpha 2 were inhibitory, betas were, think about epinephrine and what happens to you when the bear is chasing you. Then there's also cholinergic receptors. And I'm oversimplifying this, but cholinergic receptors these neurotransmitters are released by the parasympathetic nervous system, and that's acetylcholine. Remember, acetylcholine is released by the postganglionic cells of the parasympathetic nervous system. Whereas sympathetic, you're releasing epinephrine. So if you just remember that. Bear's chasing you, epinephrine, adrenaline. Parasympathetic, you're releasing acetylcholine. Acetylcholine is going to be picked up by cholinergic receptors, of which there's two flavors, nicotinic and muscarinic. The nicotinic receptors are always excitatory. Okay, they're always excitatory. And these are going to be found on muscle, they're going to be found all over the body, but always excitatory. Whereas the muscarinics, I'll jump over it, the muscarinics are typically, they can be either, but you're probably okay to think of them mostly being inhibitory. Just try to get this straight in your head. So the muscarinics are more inhibitory. In other words, acetylcholine, what can acetylcholine do? Parasympathetic, what does it do? Increases blood flow to the digestive system. So tell me what kind of receptor, think about this in general ways, what kind of receptor would be increasing digestive function with parasympathetic? It's acetylcholine, but those tissues are going to have a nicotinic receptor, and they're going to be excited by that acetylcholine. Whereas, what is cooled off by parasympathetic? The heart, right? The heart kind of relaxes. The respiratory rate goes down. Those things that we know happen when you're rest and digest, right? When you're chilling, the heart rate goes down. Acetylcholine is being released by your parasympathetic nervous system, but what must the heart have on it? Not a nicotinic receptor, but instead a muscarinic receptor. So the same hormone, right? The same neurotransmitter, ACH, is affecting tissues in different ways. Why? As Matt said earlier, the tissues have different receptor types. So acetylcholine, parasympathetic nervous system, nicotinic, excitatory, muscarinic, inhibitory. And it's okay to think that simplistic for this. Those words are kind of unfortunate because they are kind of a new territory, and the words get us all turned around and confused, I think, sometimes. Does that help? I mean, that's just one little section, right? It's just one little section, 14.5, that talks about those muscarinic and nicotinic and alpha-1 beta receptors. And I forgot that was in there, but I do have a couple questions on the test, as I recall, so I'm glad I had a chance to go over that with you. Is there something else? Yes.
What was the hormone released by the thymus gland?
Ah, you know what? I didn't go. Thymus is thymosin. Thymosin is released by the thymus, and it's involved with the development of your white blood cells and your immune system. Yeah. Was there anything else on there that you're curious about that needs to be filled in? Placenta, HCG, right? Human. HCG.
What did you say that?
Human. Yeah, it's the pregnancy hormone. It's the it's the early pregnancy test hormone. But I'm all of a sudden going blank. But that's a hormone released by that in part. Yeah. Okay. I'm going to be focusing, guys, what's on the PowerPoints. Okay. So if I didn't get to it in the PowerPoint, like the placenta or the thymus, okay, you can let go of it. So when I looked over the test and put it into the copy center, I made sure that everything on there had been discussed in some way through the lecture. Okay, so I will see you all on Thursday. Hybrid students, make sure you've made your appointment at the testing center. You're always welcome to come here at 4 o'clock. And I'm expecting great things from you on Thursday.